Good afternoon, everyone, and welcome to our weekly webinar session organized by the College of Physicians Malaysia. So for those of you who don't already know, we are doing this every Thursday, 3 to 4 p.m. And this month, we're doing hematology. And as we are already approaching September, almost to the end of the year, we're almost done with a whole cycle of subtopics also already, hematology being the last few already actually. So today's topic is on approach to pancytopenia, and we're extremely grateful to have with us here today Dr. Siang, Senior Consultant Hematologist and Physician from Hospital Ampang, who is going to be chairing our session, and Dr. Leong Shin from Sarawak, who is going to be giving us the talk. So over to you, Dr. Lau.
Okay, good afternoon to all the participants. Thank you, Marrow, for your introduction. Today's topic, I think, is approach to pancytopenia. So going to introduce Dr. Leong Siang. He's currently the consultant hematologist and also a physician at Hospital Umum Sarawak. He finished his training in clinical hematology in 2019. He completed his training both in Hospital Umum Sarawak as well as Hospital Ampang. So he is kind of interested in a lot of research. I think he done some research while he was doing his training with us in Ampang. I guess he also got a few publications when he was in Hospital Umum Sarawak. So without further ado, we'd like to listen to his recorded lectures, and then after that we will have the Q&A session, I think live. Okay, thank you.
Good day, everyone. My name is Leong Shin. I'm the clinical hematologist currently working in Sarawak General Hospital. Thank you to the College of Physicians Malaysia for giving me this opportunity to share my experience in managing patients with pancytopenia. The content of my talk is divided into two parts based on a series of case scenarios. The first half of the talk is an elaboration of approach to pancytopenia, which is going to be useful for medical officers and general physicians alike. Then we'll also briefly touch on bone marrow failure syndromes before moving on to the second half of my talk, which primarily focus on the diagnosis and treatment of aplastic anemia and the challenges we face in Malaysia. Now, please take note that I'm an adult hematologist, so the primary focus of my talk will be mostly on adult patients. Now, based on the WHO definition, pancytopenia means a reduction in O3 cell lines, meaning patients would present with anemia, leukopenia, and thrombocytopenia. The numbers shown above is just a guide, as different clinicians and labs would have different parameters and cutoff. Pediatric patients, I believe, will also have different range when it comes to these parameters. So if you can see here, figure A is a peripheral blood film. For those that have not seen a peripheral blood film, figure A is a normal blood film with normal red blood cells. So called red blood cells. Then they have white blood cells called the neutrophils here, and small little purplish dots here that we call platelets. Okay, so in figure B, the RBC, the red blood cells are very sparse. I can't see any white blood cells or neutrophils, and certainly not the platelets. So figure B is a pancytopenic blood film. Now, there's an exhaustive list when it comes to the cause of pancytopenia. But generally, they are divided into two main broad categories. It is always good to divide the causes of pancytopenia. Hypersplenism, due to its sequestration effect that pulls the blood cells in the spleen, also causes pancytopenia. And this can happen in a variety of circumstances, such as liver cirrhosis with portal hypertension. Based on the study in South Asia, now about 5 to 10% of medical admissions are associated with some form of cytopenia. So you can see from the list here, those with a marked blue stars next to them, yeah, all this. Okay, they are pancytopenia due to a true primary hematological disease that needs expert management. So about 50% of the time, maybe in fact, based on a Turkish study of about 140 patients, only about 30% of pancytopenia is due to primary hematological disease. And out of these, only about 8% is due to an acquired or inherited bone marrow failure. This means that not all pancytopenia is primary hematological badness. Medical officers and general physicians alike still need to have a systematic approach when it comes to a case of pancytopenia before referring to the respective subspecialty. This is because some of the causes are easily reversed and can even be managed as outpatients. For example, B12 and folate deficiency. Now, how do we practically approach patients with pancytopenia? I think this is the same for all diseases. Okay, when we see patients in the emergency department or in outpatient clinics, first we look at the patient, yeah? We assess their airway, breathing, circulation. We identify what is considered as emergencies. Then we can take a brief history and a targeted clinical examinations, and we ordered and send off the investigations. The question is, when do we refer these cases to hematologists or to a tertiary center? Okay, what is considered urgent? You know, what cases you need to call us at 2 o'clock in the morning, and what cases you can leave it to the next day, for example. So when do you refer to us? I mean, what are considered emergencies? These include patients with red flags, such as if their vital signs are not stable, they have symptomatic anemia, and they have bleeding, and they have wet purpura or ecchymosis, or they have, fever, or they're having septic shock. On the other hand, there's another spectrum of presentation where the patients are relatively stable and can be managed as outpatients. And these include patients who walk into the green zone, just because the family members notice that they look pale, they are rather asymptomatic with mild cytopenias. So these patients would probably require serial monitoring of their full blood count, and of course, tracing back the investigation that should be sent off, such as vitamin B12, folate level, and a peripheral blood film. And all this can be done in an outpatient setting. Okay, so once we have decided, to call the hematologist, usually, if you were to call me, I would like to hear these information, the demographics, the age, the gender, the background, okay? So the baseline and the serial full blood count. I will usually ask for the MCV, MCH, RDW, the reticulocyte counts, LDH, etc., because this gives me an overall picture of what sort of cytopenias that I'm dealing with. So I would like to know, what symptoms do they present with, what medications are they on, any over-the-counter medications or any traditional medication. I mean, this is because medication is a common cause of pancytopenia. Examination-wise, any dysmorphic features that could suggest an inherited bone marrow failure syndrome, any features that points towards, like lymphomas, leukemia, or myelofibrosis, such as hepatosplenomegaly, or palpable lymph nodes, etc. And of course, I would like to know what investigations have been sent off and whether they are traced back and what are their findings. So this diagram showed you a practical approach to pancytopenia, where your investigations are divided into those for basic evaluation and for further evaluation that you think could be the possible causes. Okay, then you would refer to us when, let's say, you suspect a primary hematological condition that requires specific evaluation, for example, a bone marrow examination. As you can see here, peripheral blood film and reticulocyte counts are two important components of evaluation. You can probably clinch the diagnosis, let's say 50% of the time, based on a peripheral blood film. Of course, I would also strongly encourage you to send a reticulocyte count. And why is that? So reticulocytes essentially are immature blood cells that are not fully developed, but released into the circulation. They are markers of red cell production in the marrow. And usually when we order a reticulocyte, they are given in reticulocyte percentage and absolute reticulocyte count. Reticulocyte count the normal range is between 0.05 to 0.1 in our local lab. In the UK, the normal range is between 50 to 100. Sometimes we can use reticulocytes as a surrogate to guide us to decide whether the pancytopenia is due to underproduction, for example, bone marrow failure, or overdestruction, for example, due to hemolysis. So beware of using reticulocyte percentage, as they are not accurate due to the calculation based on the ratio with hemoglobin. So an absolute reticulocyte count, or ARC, is a more accurate in this sense, because a lower than usual ARC suggests a bone marrow suppression, and a normal to high ARC suggests overproduction of red blood cell by the bone marrow. For example, conditions like PNH, hemolysis, and so on. Okay, let's start with a case presentation. So I have a 85-year-old female from nursing home. She's ADL dependent, bedbound, and presented with lethargy and tinge of jaundice. So the full blood count shows a pancytopenic picture with macrocytic anemia, as the MCV is very high, it's about 110. LDH is elevated as well. Reticulocytes are low, okay, 0.02. So examinations are unremarkable, except that she looks caxic and has tinge of jaundice. So a vitamin B12 folate level and a peripheral blood film was sent off. So if you look at this peripheral blood film, they are not sure whether you can appreciate this, but they are actually oval macrocytes with some polychromatic cells. Okay, and a closer look actually showed an increased anisopoikilocytosis, where there are red blood cells of different sizes and shapes. And you can see that there are actually hypersegmented neutrophils as well. And these are defined as neutrophils with 6 or more lobes, or when you have about 3% or more of neutrophil with at least 5 lobes. So the overall picture with the vitamin B12 level of 50 is consistent with megaloblastic anemia. Okay, it is worth mentioning that severe megaloblastic anemia may have marked anisopoikilocytosis with bizarre microcytes and thrombocytopenia. So these findings should not be confused with microangiopathic hemolytic anemia. Okay, so for case 1, the cause of the pancytopenia is due to vitamin B12 deficiency. Okay, so vitamin B12 and folate deficiency, they are impaired DNA synthesis, which in turn can cause the cell to arrest in the DNA synthesis phase of the cell cycle, which in turn lead to cell apoptosis. The cells can't differentiate and they can't mature properly and they become huge, hence the term megaloblast. And this forms the basis of megaloblastic changes in the bone marrow. And the apoptotic cell death forms the basis for ineffective erythropoiesis. So it's common misconception that megaloblastic anemia patients only has anemia, where in fact they can have pancytopenia, as it involves underproduction and apoptosis of all the hematopoietic cell precursors. Okay, so this is quite commonly in elderly with gastric dysfunction, but it can occur at any age. So this is a bone marrow aspirate from a patient with megaloblastic anemia. So you can see here, these are erythroid hyperplasia, okay? Or these are the megaloblastic erythroid precursors, okay? Some of them looks very bizarre, like blast. So that's why they are called megaloblasts, okay? So if you look at this, it also shows erythroid hypoplasia. But what you can notice that there's a phenomenon called the nuclear cytoplasmic asynchrony. And this describes the inability of the cell's chromatin to mature normally, giving the nucleus, a more immature, looser, and a larger appearance than expected. Okay, but the cytoplasm, they grow and mature normally. So there is, there's catching up here, where the cytoplasm grow normally, but the nucleus does not grow. Okay, so in these photos, you can also see this is a giant band form, and there are some giant metamyelocytes as well. And such abnormalities are also seen in the granulocytic series of patients with megaloblastic anemia. Okay, so take note of the risk factors for vitamin B12 deficiency, vegetarian diet, gastric surgery, small intestine disorders, elderly patients, for example. So treatment is essentially replacement of the vitamin B12 via the parental or oral route if the intrinsic factor pathway is still intact. Vitamin B12 deficiency or pernicious anemia, is a topic of its own, so I shall not dwell too much on it. Okay, so the cytopenias for vitamin B12 usually would improve and normalizes in 4 to 8 weeks upon treatment, although some more severe manifestation, such as the neuropsychiatric symptoms, sometimes would take months to resolve. Okay, so let's move on to case 2. So I have a 30-year-old male presented with a pancytopenia. He was unwell with spontaneous bruising. So this is a classical case where the red flags are all over the place, very ill, bleeding, needing urgent attention. So your differential diagnosis at this point that, this patient might have acute leukemia, plastic anemia, or some of the more urgent conditions where you need to intervene fast. So these are the red flags, they are not your usual petechial rash that you see in ITP. They are wet purpura. Some of them could in fact be a leukemic infiltration. So usually these patients will ask for an urgent peripheral blood film, and depending on which centers you are at, you should pick up your phone, call the hematologist to have a look at the peripheral blood film urgently. Okay, so this is how the peripheral blood film looks like. These are called blasts. Okay, so they are large cells, larger than your red blood cells surrounding it, with an open chromatin. Okay, very smooth, with high nuclear cytoplasmic ratio and scanty to moderate bluish cytoplasm. Okay, there is in fact some granularity seen here. So the patients were started on IV antibiotics and transfused with blood product. So the bone marrow examination was done, and it was confirmed that diagnosis of acute myeloid leukemia. So I guess the key point here for you to remember is that acute leukemia can present with pancytopenia. Some people, and in fact, you'll be surprised, some doctors would think that acute leukemia means that they should have leukocytosis, raised white blood cells, rather than leukopenia or pancytopenia. This is certainly the case for types of acute leukemia associated with bleeding called acute promyelocytic leukemia. They usually present with pancytopenia, and urgent intervention is life-saving for these type of acute leukemia. Okay, so this patient has pancytopenia due to acute myeloid leukemia. Okay, now let's move on to case number 3. Now, this case was referred to me a few months back. I have a 48-year-old lady, unwell for about 3 months, presented with pancytopenia. This time, she was admitted to the ward for poor oral intake and mild kidney injury. The pancytopenia was not too bad, not in the severe range. It turns out that, a few months ago, she was actually woke up in the nearby polyclinic. And when the autoimmune markers were traced back, they were all positive. The ANA and the anti-DS-DNA is actually positive. Nothing quite significant in the peripheral blood film. So this case was referred to hematology, okay, because of the pancytopenia. Okay, so, we have to look at the overall picture. The autoimmune markers were positive. It turns out that on further examination, the patient has a malar rash, small oral ulcers at the upper palate. So essentially, this is cytopenias related to autoimmune causes. Remember that they can present with leukopenia, thrombocytopenia, and hemolytic anemia, or even normochromic normocytic anemia. So the patient was referred to rheumatology and treated as SLE. So not all pancytopenia are blood cancers, and this pancytopenia is due to SLE, which is one of the autoimmune causes. Okay, so remember, in your systematic approach towards pancytopenia, if clinically suggestive, please send off your autoimmune screens. When in doubt, you can always consult us or even the rheumatology team. Okay, we are nice people, at least some of us are. So feel free to just pick up the phone and discuss the case with us. Okay, so now let's move on to case number 4. So I have a 75-year-old male who is a chronic alcoholic and referred to me for pancytopenia. Okay, he was very septic looking, Antibiotics were started after blood culture. So the peripheral blood film was sent, and he was referred to us because of the red flags, Patient is rather ill, so the primary team worried that, this could be acute leukemia, which is fair. So the peripheral blood film showed normochromic normocytic anemia with some echinocytes. So they are essentially red blood cells. You see, all these are called echinocytes. They are red blood cells with short, blunt, regular projections. And these can be due to chronic liver disease or even some storage changes. So as opposed to your acanthocytes, yeah, which has irregular sharp projections on the red blood cells. White cell-wise, you can see that there were neutrophils with toxic granulations. They're quite granular, okay? And there's also some vacuoles seen here, okay? So there's vacuolations with toxic granulations, and there are also presence of these inclusion bodies, a bit of rod-like inclusion bodies here, okay? If you can appreciate here. So, so essentially, this is a peripheral blood film that shows that patient is having a severe reactive inflammation, such as an infection. So what did I do with the patient? So I didn't do anything, I just continue on with the antibiotics treatment, and the blood culture grew Listeria monogenes, which is a bit rare. But in short, this is a pancytopenia due to severe sepsis, which is quite common. Marrow is someone shocked by the sepsis with hypoperfusion, and it takes time for it to recover. Treatment is treating the underlying cause and support the patient throughout. In certain conditions, you might need to consider the differential diagnosis of HLH, but this is a different topic altogether, and I won't elaborate more on it. Okay, so finally, let's move on to talking about the real deal here. Okay, about 2-3 months ago, I was referred a 67-year-old pensioner. Okay. Quite a pleasant looking man, rather fit. He came in with unprovoked gum bleeding. Okay, so he was pancytopenic, So what is your next step of management? Okay, so what would you do next? So like what I mentioned earlier on, a systematic approach to this case, yeah? The history examination is rather unremarkable, and relevant investigation was done. All the iron, folate, B12 virus screens were all negative. So the peripheral blood film essentially shows a pancytopenic picture. There's no circulating blast. Like what I mentioned earlier on, the absolute reticulocyte count is important, and it was very low in this patient. It's about 0.013. The normal range in our lab is 0.03 to 0.12. So as I've mentioned earlier on, anything very low, in fact, lower than 0.02, we have to consider a diagnosis of bone marrow failure, such as severe plastic anemia. So patients was counseled for a bone marrow examination. So you can see in figure B here, okay, this is a hypocellular marrow atrophying, okay? Hardly any cells in between these bony trabeculae, okay? All replaced by all these adipose tissues, okay? Which is the case for our patient, yeah? So it was a dry tap from the aspirate. A, meanwhile, showed a normal cellular marrow. These are the bony trabeculae. There are some fat space, but you can still see a series of, hemopoietic precursors, the erythroid granulocytic precursors, and even some megakaryocytes around. Okay, so so can you appreciate the difference? This one looks rather empty, and this one looks, have cells in between them. So the trophine biopsy of the patient in case 5 was reported as hypocellular with only 10% of cellularity, which is very low. Okay, so let's just recap back and remember our approach to pancytopenia. Okay, so there are a lot of causes. Okay, marrow failure is one of them. So, but they only make up about 8 to 10% of all the causes of pancytopenia. So it is still very important for you to rule out all the secondary causes. Okay, so what exactly are bone marrow failure syndrome? So this essentially is a cluster of conditions. Okay, so that's why they are called a syndrome. Okay, so it is a group of disorders that manifest as single cytopenias or as pancytopenia, and it can be either inherited or acquired. Okay, so after you have done a bone marrow and established that this is bone marrow failure, there's a reduction in trilineage hemopoietic cells, and you are certain that this is not due to secondary causes, the next step to decide is whether this is inherited or acquired. Okay, there's quite an extensive list of different conditions that are associated with bone marrow failure, but essentially inherited marrow failure is more related to the pediatric population. However, as we see patients that are 12 years old and above, which sometimes I don't quite agree when it comes to patients with hematological diseases. But anyway, these inherited conditions, especially if their presentations are very subtle, they might be missed out when they are very young. We might encounter them in adolescence or young adult age group. So it's important to recognize these features, okay? Plus, they come out in your FRC path exam, asking you to match these inherited conditions to their specific gene mutations and what syndrome do they present or anomalies they present with. So it's always good to know about your Fanconi anemia, your dyskeratosis congenita, your Diamond-Blackfan anemia, your Schramm-Diamond syndrome, and so on. So how do you differentiate an acquired versus an inherited cause of marrow failure? So there are some clues to the etiology. Okay, if they have a rapid onset with prior normal baseline full blood count, there's no family history, but they have preceding illness such as upper respiratory tract infection or fever or some autoimmune associations, then this could be an acquired bone marrow failure. Okay, but on the other hand, if these symptoms are rather subtle, they have borderline or abnormal baseline full blood count with family history, or even they look syndromic, then you should think that whether this is inherited bone marrow failure syndrome. So why is differentiating them important? Because treatment would differ. Okay, if this is an acquired cause, it can be treated with immunosuppression. So like your ATG or cyclosporine, which I'm going to explain a bit more later on. But if this is an inherited condition, the only cure is transplant. Furthermore, the family donor for the bone marrow transplant also need to be assessed clearly, because this could potentially be an inherited problem where the donor could have the same problem as well. Okay, so most of the time, this inherited bone marrow syndrome would require a special test. For example, for Fanconi anemia, you will need to do a chromosomal breakage study via the mitomycin C or deoxybutane test or DEB test. So in Malaysia, it's used to be done by the Institute of Medical Research, IMR, but the service was interrupted due to them shifting to Setia Alam. Essentially, I'm not sure whether they have started back the service, but you need to make an appointment to send this blood. The results would be something like this. Okay, they will report it like this. These are where the breakages are. So it takes a lot of time to look at these different sort of breakages to come out with the interpretation. So the turnaround time is understandably long. Okay, so I have asked my pediatric colleagues. Apparently USM is offering these tests as well, but there's a long waiting list. Some of the pediatric colleagues would send these blood to University Malaya Peds Oncology Lab after discussion with their boss, but that is out of their own initiative and without out-of-pocket expenditure. Okay. On the other hand, there are a variety of gene mutations associated with these inherited bone marrow failure syndrome. The common ones that always come up in exams are your FANCA, so the FANCA, A, B, C, all these are related to Fanconi anemia. So you have your DKC and your TRC that is related to telomere disorders such as dyskeratosis congenita, and SBDS, RPL for your Diamond-Blackfan anemia, and so on. So you can actually send this genetic test to USA, okay, via a company called Invitae. Okay, they charge about USD about $250, about $1,000. Excluding the postage and your effort of doing the export permit and coordinating everything. Yeah? So usually it gives me a lot of gastric pain, and thank God that I do not need to do this very often. So apparently there's a company in KL also have this service. It's called Oncode, but they outsource it to a lab in Finland, and it costs about 4,000 to 5,000 ringgit. Okay, so let's go back to case number 5. Let's shift our gear back to case number 5. So in summary, here's a 67-year-old male. Full blood count a year ago was normal. Everything goes downhill started about a month ago when he started to have, a flu or URTI, but he has a COVID swab done and it was negative. So this sounded like something acquired, right? So not inherited, especially with this age group. Screening test was done to rule out secondary causes and all negative. Then we proceed to do a bone marrow examination that showed a hypocellular marrow, and hence establishing that, this is bone marrow failure. So this is an acquired bone marrow failure. So the most common cause would be aplastic anemia. So how do you diagnose aplastic anemia? Okay, so this is based on the Prometa criteria established in 1975. However, it was modified again in 1988 to be more precise, where the hemoglobin parameters was taken out, but replaced by the absolute reticulocyte count. So in the absence of an abnormal infiltration or a marrow fibrosis, we diagnose SAA or severe aplastic anemia as, having a marrow cellularity of less than 25%, plus at least two of the following: neutrophils of less than 0.5. If they are less than 0.2, they are called very severe aplastic anemia. Platelet count of less than 20, and a reticulocyte count of less than 0.02, or less than 0.06 if they are using an automated machine to count. They tend to overestimate the reticulocyte count. So our patients definitely fits into this category, yeah? The marrow cellularity was 10%. He has an absolute neutrophil count of 0.43. Platelet count is less than 20, it's about 17. And his reticulocyte count was very low, 0.01. So he fulfilled all the parameters for a diagnosis of severe aplastic anemia. Okay? Just a quick fact on acquired aplastic anemia. Okay? 70 to 80% of the time, they are idiopathic, though the causes would range from, chemical exposure, hepatitis. I have a patient with hepatitis C and they have aplastic anemia and other viral infection as well. And they usually comes in two peaks, either in young adults or in, can't say they're elderly, but older group of patients in their, 50s or 60s. So what exactly caused acquired aplastic anemia? So it was postulated that exposure to virus or chemical triggers these autoimmune T cells and causing them to activate and expand and migrate to the bone marrow. And these T cells would then directly destroy the marrow stem cells and produce cytokines and cause marrow suppression and hence aplastic anemia. So how do we treat acquired aplastic anemia? So after the past 30 minutes or so, we will have gone through and appreciate, the complexities from the presentation of pancytopenia to the diagnosis of aplastic anemia. Okay, how much work are needed, to get the diagnosis in hematology? Getting the correct diagnosis is very important because it affects your treatment plan. Okay, after a correct diagnosis, the treatment algorithm would be rather straightforward, and you can find them in most of the books or protocols. But to get that diagnosis is so difficult. Okay, it is sometimes more difficult than you can imagine. Sometimes we run into trouble as well. Okay, so once you have diagnosed someone of having aplastic anemia, the next step, of course, is to determine the severity. Okay, so for our patient, no doubt that he has severe aplastic anemia. But if your platelet count is more than 20 and the absolute neutrophil count is more than 0.5, then you do not fit into the criteria of severe aplastic anemia. You may be a moderate or non-severe aplastic anemia. So I very often come across these patients, they're called non-severe aplastic anemia. So the private physicians sometimes would open their mouth saying that, transplant is the only cure. They need to go for transplant stat. So the case was referred to as stat. So we have to see them stat. So you imagine, parents of their children in their teens or early 20s who are diagnosed with the so-called moderate aplastic anemia, especially, Asian parents who have invested so much on their children, yeah? They will have a shock of their life. In fact, some of them will even relocate themselves and do everything they can just to save their children, So I have one case who shifted all the way from Cebu to Kuching, the entire family, just so that they can come to seek hematologist treatment for an allogeneic stem cell transplant. But we have to look at the overall picture, their blood parameters. Transplant is not godsend, it's not a miracle cure. For those that have done transplant, I think you know what I mean. Okay, we always have to weigh the risk and benefit and only treat or transplant when the indication is there, especially in this COVID era where everything is so unpredictable. Yeah, so it is still associated with mortality about 15 to 20%. Okay, so in short, we only treat or intervene when they are transfusion dependent, they have recurrent infection due to the neutropenia, or they have recurrent bleeding due to the thrombocytopenia. Okay, some of the treatment that you would consider single agent, for example, cyclosporine, L-Trombopac. You know, some of us would just watch and wait. Okay, but I mean, you can still prep, okay, the patient early by trying to find a HLA matched sibling as the disease would progress in the future. Okay, so let's go on to the management of acquired aplastic anemia. So if you look at this diagram, after we have established the diagnosis and the severity, the next step is, of course, to provide supportive care as needed. Okay, so patients with aplastic anemia would require this supportive care. They need filtered or leukodepleted and irradiated blood, if possible, especially if they are on immunosuppression. The threshold for transfusion should be individualized. Okay, iron chelation should also be considered, especially if they are heavily transfused prior to transplant, as it is always associated with a poorer outcome. So normally we chelate them with Desferal or XJ, Deferral Syrox, but these are expensive, and we have to be very careful with kidney function, and these patients usually are on cyclosporine. So definitely no role for deferoxamine, as L1 can cause air granulocytosis. Okay, prevention of infection would be based on the local SOP. Some people would give Bactrim or pentamidine nab as a PCP prophylaxis. Some patients would be on antifungal like fluconazole or voriconazole or even posaconazole, but these antifungals are very expensive. Some patients would be for antiviral for HSV like your aciclovir. Okay, so all these are based on local SOP. So, but all these medications are expensive, you see. So usually we will just give when it is needed. Okay, so GCSF and EPO, such as your Recomon or Iprex, is not known to be useful because they act only on lagged progenitor hemopoietic cells. And these levels are usually endogenously high in patients with aplastic anemia. TPO agonists, on the other hand, such as L-Trombopac, has been proven to be useful as it acts on the early hemopoietic progenitor cells. We shall talk a bit more about this later on. So it is quite straightforward. I mean, if you are less than 40 years old, the mainstay of treatment is sibling HLA-matched allogeneic stem cell transplant. If this is not available, or if patient is more than 40 years of age, treatment would be immunosuppressive agent called IST with agents like ATG with cyclosporine, and in addition to that, plus minus L-Trombopac, if the institution or the patient can afford it. If the disease relapse despite all this treatment, then you can retry with a rabbit ATG or add in L-Trombopac if you have not used it early on. But if you are young and fit, and transplant eligible, you might want to consider a match unrelated donor transplant. Some centers will even consider a haplo or a cord blood transplant. So toxicity related to transplantation as well as a GVHD is always a problem for patients older than 40 years of age, and they are associated with a high mortality. That's why there is always a cutoff point of 40 years of age here. Okay, so like what I mentioned earlier on, for those less than 40 years of age with a matched sibling donor, the ultimate treatment is allogeneic stem cell transplant. So if you have a case of a young patient in district hospital whom you suspect is severe aplastic anemia, please liaise urgently with us. HLA typing should be done urgently, and aim is to transplant within 2 weeks. Okay. However, from experience, I mean, it's just quite hard to achieve this target, especially for those that are in East Malaysia like Sabah and Sarawak, where it is just logistically and mentally challenging for the patients and the physicians alike to achieve this. But it is possible. I mean, the photos here, showed a donor bone marrow harvest in Ampang Hospital for a severe aplastic anemia patient from Miri, Sarawak. That's me here. Yeah. And this is, I think it's Dr. Gilbert, one of the hematologists from Sabah. And these are the marrow harvest stem cells that are going to be infused into the patient. So a big thank you to Dr. Ho, our transplanter from Ampang Hospital, for providing me with this figure. You know, Ampang Hospital has transplanted about 70 cases of severe aplastic anemia for the past 10 years, averaging about 6 to 7 cases a year. So the 5-year overall survival are not too bad, about 65%, close to the international standards of about, 70%. Okay, though I think the next 5 to 10 years time, the survival probably will go up to about 80 to 90%. Okay, so just to recap back, for our case number 5. So our gentleman is a 67-year-old guy. So transplant is not an option for him. He is non-transplant eligible. So the next available treatment for him would be immunosuppressive therapy plus eltrombopag if he can afford. So the standard of care for the past 10 years when I was as a medical officer was a combination of what we call as ATG or host ATG, anti-thymocyte globulin, with cyclosporine. Okay, so patients need to be admitted for at least 2 weeks in the hospital with a central line, with daily or BD, or twice a day irradiated platelet and an intermittent packed cell transfusion. The infusional reaction can sometimes be very severe despite them on high dose corticosteroids to prevent serum sickness. And also if they are on pre-medication, sometimes they can have very bad chills and wriggles. The entire bed would literally shakes, and not in a good way. Yeah. So the overall response rate is probably about 60 to 70%. So a 2/3 of the patients would achieve remission. And patients would then need to be on cyclosporine for the next 6 to 12 months. And we have to watch out for side effects like, renal impairment, hypertension, gum hypertrophy, or like tremor, the signs of a cyclosporine toxicity. These are the favorite questions they will ask in MRCP. Yeah. So how about eltrombopag? Okay. So this is somewhat of a new kids on the block for the past 5 years, and it's been used in relapsed severe aplastic anemia, and it has a response rate of about 40%. So trying not to be a drug rap here, but this medication have somewhat, or maybe has changed the landscape of severe aplastic anemia treatment for the past 5-10 years or so. This is, but however, the caveat is that this is provided that you have the financial means to purchase this medication. Okay, it is called Revelate or Prometa in some country. They are usually selling it in a box of 28 tablets of 25 milligram. Some can have it in 50 milligram. The cost is about 3,000 ringgit a month for the 25 milligram box. So it is very expensive, yeah? And it is a synthetic TPO receptor agonist, initially licensed for use in chronic ITP. But it was later discovered that it has a stimulatory effects towards the growth of early hemopoietic precursors of other lineages as well. So even stimulating the pluripotent stem cells. So it is got very, very excited. So people have do trials on different scenarios when it comes to aplastic anemia with eltrombopag. So for refractory SAA, so according to Desmond et al., they tested on 44 patients. The ORR is about 40% at 6 months. And the next study by Townsley in 2017, which led to the approval of Revelate or eltrombopag in the first line use in severe aplastic anemia, is based on this study, where it is a non-randomized phase 2 study where we tested on about 92 patients. So a combination of immunosuppressive therapy, ATG and cyclosporine with eltrombopag. And then they divide them into 3 cohorts where they start the eltrombopag at different time. And if the eltrombopag was started from day 1 up to 6 months, they have an overall response rate of 90%. So it is very impressive. And the CR rate is also very impressive, about 35 to 40% at 6 months. However, it still has a relapse rate of about 15%, especially as you withdraw the eltrombopag. And the 2-year cumulative incidence of clonal evolution is about 5 to 10%. Okay, so fresh off the oven this year in EHA 2021 is a single-arm phase 2 study done by, I don't know how to pronounce it, but an Italian, where this study is called a SOAR study, SOAR, where they combine cyclosporine to eltrombopag as upfront treatment for severe aplastic anemia. And this is especially relevant for patients, they are considered not fit for ATG. In fact, ATG is associated with an increased mortality for those that are more than 60 years of age due to its immunosuppression effect. So as I mentioned earlier on, this is called a SOUL study where they recruited about 54 patients and it shows an ORR about 46%. However, the response rates are much lower in the elderly age group. Anyone more than 65 years old, their response rate is probably just about a third. Okay, but overall, eltrombopag is a well-tolerated medications, although you can present with adverse effects such as rash, skin reactions, or even elevated liver function tests. Okay, so the schedule and protocol for response monitoring varies by institution. Okay, so and there's no consensus regarding the optimal approach. So during the first 6 months of IST, we generally scheduled outpatient visits every 2 to 4 weeks, or as clinically indicated. And when we look at the responses, the definite responses also varied from trials to trials with different cutoff. Different physicians would also have a different cutoff based on their experience and what they considered as a complete partial response or treatment failure. In terms of monitoring, sorry, I just go back to the responses. So for me, I'll aim for FBC recovery in the first 6 to 12 months. Complete response would mean that platelets have recovered up to 50 to 100. If the absolute neutrophil counts go up more than 0.5 and patients are transfusion independent, though the platelet count is still low, I will consider them as a partial responder. But however, if by 3 months the absolute neutrophil count is still less than 0.5, or they are still transfusion dependent by 6 months, then I'll consider them as treatment failure. Okay, so in terms of monitoring, is there a value to repeat a bone marrow examination? Well, it depends on which center you are at. I don't repeat, but you may repeat every 3 to 6 monthly. The trials certainly do so. Some are doing that, to look for clonal evolutions to MDS. As we know, MDS, aplastic anemia, and PNH, they can interchangeably happen, okay, because of the clonal evolutions. It is a cluster of disease that tends to have these evolutionary properties. Okay, so sometimes you do a marrow to check to see whether have they transformed into MDS. Some will just do it if there is a rapid drop in the blood counts after an initial recovery, let's say. So some would probably repeat one before they initiate like a new alternative therapy, just to make sure that they're dealing with the same disease. Okay, and how about if the patient is on eltrombopag? If based on the Townsley study, they are on eltrombopag for 6 months, do you continue them? Do you taper them off? Do you off them straight away? There's no clear-cut answer because the relapse rate is still about 15%. Okay, so going back to our case, our patient has severe aplastic anemia. He's more than 60 years old. He's retired, so he has an option of using pensions fund for eltrombopag. So we decided to combine cyclosporine with eltrombopag as per the SOAR trial. Okay, so but we have to taper down the cyclosporine because the patient developed hypertension, and the eltrombopag was at 100 milligram OD because of stock issue, and then we increased it to 150 milligram OD. So it's like 6 boxes of eltrombopag of 25 milligram of 28 tablets a month. Okay, so 3,000 times 6 is about 18K a month. Okay, so how is he doing so far? I mean, he's on a 3 to 4 weekly transfusion now. The absolute neutrophil counts, as you can see here, has gone up to about 1.29. So remember, it was 0.43 before this. So I mean, it's probably a partial response now. Okay, so finger crossed. Okay, so he used up about 40K now. So let's persevere for like, let's say another 4 months, let's say, maybe to see whether is there any response. By then, he will have used up maybe about 120K worth of OTIS. Okay, so who says being a government servant has a bad job prospect? Okay, certainly we can afford to give him eltrombopag because he is a pensioner. Okay, so last bit about aplastic anemia in Malaysia before we wrap up. Yeah, so my colleague Dr. Grace has done a retrospective study on aplastic anemia in Sabah and Sarawak. So she retrospectively collected data on about 112 patients who are treated in the span of 12 years, and you can see that this 5-year overall survival for VSAA is about 60%. Not bad, okay, considering we are at Sabah and Sarawak. So some of the challenges that we face in Malaysia, okay, when it comes to the management of aplastic anemia. there's always a delay in diagnosis, as I think that the general idea of how to approach pancytopenia is still lacking in the fraternity. Yeah, so this could be one of the cause. Hopefully this talk would improve such knowledge. And once we have diagnosed someone with aplastic anemia, if they are transplant eligible, okay, please refer them to us urgently. And they would actually need an urgent HLA typing for patients and siblings, because the entire public hospital in Malaysia uses IMR as their only center to do HLA typing. There's always a wait list. Though I have to say, our colleague in IMR and PDN has been very patient and accommodative to our needs. Okay, there's always an issue with funding for ATG and L-Trombopac. They are not entirely cheap. And lastly, it is always logistically and mentally difficult, for us in Sabah and Sarawak when we talked about allogeneic stem cell transplant in Ampang Hospital for patients with severe aplastic anemia who are transplant eligible and have a matched sibling. Because, they have to stay put in Ampang for at least 3 to 4 months. Okay. Furthermore, compliance to immunosuppressive therapy is also another issue, as a portion of them, a portion of the patients, they are young adults. Most of them are young adults. Okay. They want to have fun. How can they be compliant to the medication? So in conclusion, not all pancytopenia are hematological badness. Do not panic when you encounter a case of pancytopenia. Keep an open mind, okay, to the differential diagnosis and the different secondary causes of pancytopenia. So, and lastly, approach your case systematically and consult us if you have any problem. Okay, so this chart is very important. With that, thank you very much, everyone. Stay safe, and this is the end of my presentation.
Okay, not sure whether I can start now. Okay, hi, Dr. Lau here. Is Dr. Leong? Can I see his face?
Yes, I'm here, Dr. Lau.
Oh, okay,
Hello,
yeah,
everyone.
right. Hello, hi, how are you? Yeah, in the
good.
clinic, are still working, is it?
Yeah, this is our new daycare in
New daycare.
Sarawak General Hospital. Yeah.
Oh, so this is South Sarawak or North Sarawak?
Sarawak.
South Kuching or North Kuching?
Kuching.
Okay. Thank you very much for your very elaborative talk. I think this covered a lot of things. So I guess there are quite a few physicians as medical officers in this group, and I was looking at the chat box. I think there's a question. Say, will this recording be available to us later? I'm not sure that the Mabel.
Yeah. The recording will be available on it's on YouTube actually. This is on YouTube.
So you just need to type in YouTube and then Academy of Physicians.
On YouTube, look for College of Physicians Malaysia. Then you will find all the webinars from way before. So today's session is also should be already on YouTube actually. If not, alternatively, for those who have Facebook, you guys can search for College of Physicians as well.
Oh, okay. So it's on the Facebook, maybe also on the Instagram or something like that. I don't know.
Facebook and YouTube, no Instagram yet. So.
No Instagram yet. Or maybe you can put there as well, at least a bit more active. I guess young people love more pictures.
Sure. I will suggest to the college to start a
It's free, right? Instagram is free, right?
Yeah, Instagram is free.
Also, TikTok is also free, right? I thought those are free. Yeah, to attract more young people.
Definitely.
Yeah, okay. So maybe so just a few questions for Dr. Leong. Okay, so I guess Dr. Leong is very handsome and nice, so he always is nice to pick up the phone and answer most of the questions about pancytopenia. But as a medical officer that working in a district hospital like Kapit, I'm not sure Kapit nowadays is already a bit more developed now. Just like me, when 20 years ago I was working in Tapa Hospital, I'm very scared to call the hematologist. So fierce. Okay, So you think that is advisable just to upfront to send everybody who come with pancytopenia with all the blood tests, including your B12, folate, Hep B, HIV screening, blah, 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 including your ANA. After that, maybe how many days you think that need to wait while waiting for the fevers to settle and then decide bone marrow, Dr. Leong?
Yeah, so I used to work in Kapit for about a year, so I know how the situation is there. So I'm a good friend with a Kapit physician now, so they usually will text me. So it's very easy and very approachable.
That's why you are so handsome. They dare not text you. You are already obliged, but to tackle the fierce physician hematologist, how?
Yeah, I guess like what I showed in my early on slides, the approach to pancytopenia, it's all the matter of urgency. So you look at the red flags. If the patient is rather ill or having all these red flags, have very wet purpura, they are bleeding away, they have infection, regular transfusions, or the HB is very low. And when you look at the patients, they look ill, they are septic looking and so on. Then I think these patients, they warrant urgent investigation. So in a way, you can send off all your investigation. But for me, a peripheral blood film is very, very useful. So nowadays, since I came back to Kuching, I've always tried to educate my young physicians and all the medical officers. If I have time, I'll bring them to have a look at least touch and feel and have a look at the microscope, because you can do peripheral blood smear in all, even in small hospitals, all the MLTs know how to do it. After he has smeared it, you can actually get it stained, send a copy to a site that has a hematopathologist, and you can personally actually go down to the lab, have a look under the microscope of the findings of the peripheral blood film. So if you have not seen one, of course, you don't know what is abnormal. So what I usually do is I'll ask them to snap, through the microscope lens there. You're actually using your smartphone, you can actually snap quite good pictures. And I've been doing that actually all over Sarawak. Sometimes because the slides do not reach the centers very quick. So sometimes I clinically, let's say if a patient is bleeding, and I ask the MO or the specialist to, stain and smear and stain the peripheral blood film and look under the microscope and then show it to me. So let's say if I see bilobes, I see, our it's very granular and all those. Then I'll treat empirically as a PML before sending the patient down to a center with blood support, like platelets. They must have enough platelets and PEG cells and so on. So I think a systematic approach is important. The important thing is we are clinician. We look at the patient. We still need to, if they are ill, assess the patient, look at the ABCs. If they are ill, I think we need to send down to a center where you think that if you are not able to manage, then you have sent to a bigger tertiary center like Kapit, you will send to like Cebu. Yeah.
Okay, all right, thank you very much. Okay, I think I'm going to get two questions here. Would like to ask regarding the duration of L-thrombopeg treatment. I guess is applicable to the aplastic anemia topic just now you mentioned.
Yeah, the second half of my talk. So there are 3 trials. I said one of them is the use of L-thrombopeg in the relapsed refractory setting of plastic anemia. The other 2 trials that, the other one is by Townsley, where they divide the patients into 3 cohorts. So they start their L-thrombopeg at either day 1 to 6 months, another one at day 14 to 3 months, and another one at day 1 to 6 months, day 14 to 6 months, and day 14 to 3 months. So I think the duration for most of the trials is up to 6 months. So up to 6 months, they'll stop, and then after that, they'll follow up on the patients. So this data has shown that actually the relapse rate is about 15 to 20%. So they still do relapse. So if you were to ask me that how long do you need to keep this L-thrombopeg, I have no exact answer for you, but most of the trials stop it at 6 months. But personally, for me, you can probably continue if you have the financial means to do it. Of course, there's another consideration. People worried about clonal evolution when they start patients on L-thrombopeg. So for the trials that I mentioned earlier on, so there's about 10 to 15% that, that may evolve into something else. Yep, so yeah.
Oh. Yeah, okay, right. Okay, so I think there's another question. What is the platelet level you should be happy to do bone marrow?
Okay, so I'll share with you my experience in CAPIT. I've actually done a bone marrow on a patient with a platelet count of 2 in CAPIT. So I guess it is very, very risky, I know, but it all depends on how comfortable you are and whether you have support available to you. So for me, you still have to look at the patients. If they are a bleeder, even with a platelet count of 20, 30, you would still be cautious and maybe transfuse them with platelet before you do your bone marrow examination. But if they are a non-bleeder, they are rather stable, but later on you will think that, you know what, the indication to do a bone marrow if they're so stable and they're not bleeding away. So I mean, all these things, it all depends on how comfortable you are. But for me personally, anything below 20, I'll be a little bit iffy, but there would not be a cutoff point, let's say if patient already is a bleeder.
So I guess it all depends on the experience. If you do 50 bone marrow a year, then you can close your eye with single-digit platelet, also you can do bone marrow, right? More so if you think that you want a good trophy. So I mean, obviously, a good trophy is essentially quite important for some of the important pancytopenia investigation. So I guess it really depends on. I mean, if you're just starting to do bone marrow, and then for the first 5 bone marrow, maybe you should not.
Yeah, so it
okay?
all depends on your how
talk to the
comfortable you are.
hematologist also, yeah, and your support, I guess. I think there's generally I think one comment about say, is it wrong to use deferripron in aplastic anemia? Do you mention it in your?
Yeah. So my colleague has corrected me a few times. So I think I wrote wrongly in the slides. I've written there deferoxamine, but actually what I mean is deferipron. So there's a mistake in the typo there. So I think it's a sin for us to confuse all the iron chelation therapy, but they all sounded very, very similar to each other. So there is always a concern for us to use deferipron because L1 is sometimes associated with agranulocytosis. But it varies. Some people are quite comfortable in using them. But for me, in my center or in Ampang, usually we still go for Desferal. But the guideline says that, you know, XJ is quite safe. Of course, you have to be aware that these patients usually are on cyclosporine. So monitoring the kidney function is important.
Okay.
Okay, I think there's another question. Maybe we allow another 2 questions. Yes. Oh, yeah, going to finish, right? So no more question. Time's up. Okay, good.
Anything you can text me, no problem. I can ask from Mabel.
Yeah.
You got the has got an email, right? Email,
you
right?
Can email me. You can ask me questions in YouTube. No problem.
Yes. You got Facebook or not? Yeah, you put your Facebook or Instagram there. Yeah, so they can directly look for you in the social media. That'd be great, right? Yeah.
No problem. Okay.
Okay.
Thank you,
Yeah,
everyone.
Dr. Mabel.
Okay,
Anything else?
Thank you. No more. Just join us next week again on Thursday, 3 to 4 p.m. Very interesting topic and relevant on VITT, vaccine-induced thrombocytopenia. So thank you, everyone. Thank you, Dr. Leong. Thank you, Dr. Lau.
All right.
Thank you very much, everybody. Stay safe. Bye-bye.
Bye.